Welcome back. Our next speaker is Vladimir Maletic, who is a highly sought after faculty member for conferences across the country. Many in the audience will recognize him from speaking here at the symposium last year, but also as a fixture at Psych Congress. Dr. Maletic is a clinical professor of psychiatry and behavioral sciences at the University of South Carolina School of Medicine.
My name is Vladimir Maletic. I am clinical professor of psychiatry and behavioral science at the University of South Carolina School of Medicine in Greenville, South Carolina. Topic of our conversation today are the new horizons in the treatment of major depressive disorder. Well, hopefully in the course of this conversation, you will find out a little bit more about the advances in our understanding of neurobiological underpinning of major depressive disorder, and also what may be some new medication approaches that will offer hope and hopefully improved symptom relief for some of our depressed patients. These are my faculty disclosures and the overview of our agenda. So we will begin by identifying some of the current challenges. Our patients are doing better, but we are still woefully short of our ideal goal, which is to bring our patients suffering from major depressive disorder to remission. We will further on describe advances in neurobiological understanding of major depressive disorder and look at what some of these pathways and neurotransmitter systems may be promising targets for future therapies. Finally, we will evaluate some of the clinical and pharmacologic data of emerging treatments. There are some of them that are already on the market, and there are some that will hopefully very soon be available to us. And finally, we will look at how we can incorporate some of these emerging treatments into more effective treatment plans. So to start with gaps, to start with discrepancy between how we would ideally want to help our depressed patients and where our current clinical science is. I know you have all seen so many slides about STAR-D. So we will try to extract some data that is not typically mentioned in discussion of STAR-D. Talking about shortcomings, this is outcome of the first phase of STAR-D, where patients receive 12 weeks of an SSRI treatment. How are things looking at the end of those 3 months? Well, about 40% of the patients still had moderate, severe, and very severe symptoms of depression. 40%. So a lot of individuals are suffering, and as we know, it's not only an individual that suffers from depression, it is the entire social grouping. So if they're not doing well, their families are not going to be doing well. Their children will not be doing well. Their coworkers will have greater load because of so-called presenteeism, where even if individual is coming back to work, they're walking wounded. They're not functioning at their full capacity. Their social relationships with peers and friends are also sometimes strained due to the presence of their illness. So again, 40% of individuals still significantly suffering after 3 months of treatment with an SSRI. Well, reality is actually even bleaker than it initially appeared, because one thing is to achieve remission at a certain time point. The other is to be able to sustain that remission. So let's see how these individuals in STAR-D fared. This is level 1. And you see, while approximately 37% of the patients did achieve remission, in the end of 12 months, only 25% retained it. So about 1/3 of these patients who did achieve remission no longer were in remission 12 months later. How about step 2? Even worse. It is now 60% of individuals who achieved remission at the conclusion of this phase did not retain it for entire 12 months. And things get even more bleak as we go to steps 3 and 4. Absolutely worst case scenario, level 4, where less than a quarter of the patients retained their remission status after 12 months. So not only as we go through series of monoamine modulating interventions and even into these heroic combinations of monoamine modulating antidepressants, very low remission numbers, even more concerning. Even this hard-fought and reach remission is not retained. Patients will get sick again very quickly. So the obvious question is, why? And are we looking at the wrong place? The answer is much more complex, because it is clear that a good portion of our depressed patients will respond and remit if we're using monoamine modulating antidepressants. So if we can get 1/3 of the patients well, that's still something. I would not toss that out of the window. But I would also be curious, is there something else that we can be doing? And another big question, these patients who are not remitting after first couple of phases in STAR-D, might they be neurobiologically different? Is it possible that monoamine dysfunction is not the primary contributor to their depressive pathology? So let us start to peel back some of these layers and hopefully get closer to the answers. So I mentioned that as we go through steps of STAR-D, patients are achieving remission in lower and lower rate and even less ability to maintain that remission. Well, we're finding something else that is quite interesting and relevant to our clinical practices. And that is, as we go through steps 3 and 4, and we engage in these more exotic combinations, such as combining tricyclics and mirtazapine, we are seeing that a ratio between likelihood of remission and odds of patients stopping medicine because of adverse reactions becoming more and more unfavorable. So in steps 3 and 4, patients who are discontinuing due to adverse reactions are twice as great as the numbers of the patients who are actually remitting. So the odds are 2 to 1 that patients will stop the medicine because they can't tolerate it versus achieving remission with this complex intervention. Indeed, it is informing us that we need to be doing something different and that we need to be thinking about major depressive disorder in a different way. So while it doesn't look very good at steps 3 and 4, step 2 looked quite a bit better until we paid closer attention to what is going on. What do I mean when I say closer attention? Well, in step 2, this is when SSRI non-responders were randomized to receive another SSRI, an SNRI, or norepinephrine dopamine reuptake inhibiting agent. There was possibility of CBT treatment also added into the mix. What did we find out? We found out that only after failing one SSRI, about 45% of individuals in step 2, so this is pretty early in our protocol, needed more than 9 weeks to achieve remission. Now with SSRIs and SNRIs, based on the preclinical studies, we have increase in serotonin and norepinephrine within a matter of hours. So if indeed it was a lack of serotonin and norepinephrine transmission, how do we explain that about 45% of the patients needed more than 9 weeks to reach remission with a medicine that raises monoamine levels within a matter of hours? A possible explanation is that monoamine transmission is not the proximal cause. It is that by introducing monoamine modulating antidepressants, we are creating a disequilibrium in the brain. And that brain's attempt to reestablish equilibrium In other words, to adapt to the medicine is what is associated with antidepressant response. So it's not a direct effect of antidepressants. It is way downstream. It is brain adapting to antidepressant that in some individuals is associated with antidepressant response. There are now meta-analyses more closely examining monoamine transmission in the brains of individuals who have major depressive disorder. So what you're looking at here is one of those meta-analyses. It included 11 studies and large number of depressed patients, around 400. It was comparison between depressed and non-depressed, focus of interest, serotonin metabolites such as 5-hydroxyindolacetic acid, and norepinephrine and metabolites such as MHPG. And if you look at these graphs, you will see that there is a scatter. So in terms of serotonin and norepinephrine regulation, our depressed patients are not monolithic group. They're not homogeneous. These outcomes are all over the place. Some have no difference in norepinephrine and serotonin transmission. Some seem to have increased turnover of serotonin and norepinephrine. Some of them have decreased turnover of serotonin and norepinephrine. Driving home a very important message. MDD is not a single disease. This is a cluster of conditions that have similar symptomatic manifestations. So outwardly, they appear to be similar, but under the surface, these depressions, and rightfully we should be referring to them in plural, these depressions are very different. The conclusion of this study, as puzzling as it is that overall, there doesn't seem to be a pattern of difference in cerebrospinal fluid, so brain metabolites of serotonin and norepinephrine. Overall, if you put it all together, are no different in individuals who have depression versus the ones who do not. And that may explain this heterogeneity in response to monoamine modulating antidepressants. Another study took on a different approach. This is an attempt to use pharmacologic probes to assess norepinephrine and serotonin function. So if we use dexfenfluramine, which is a very robust serotonin releaser, dexfenfluramine to serotonin is something along the lines of cocaine to norepinephrine and dopamine. It releases a lot of serotonin. There are functional outcomes of increased serotonin signaling, as in serotonin is involved in modulating prolactin release, primarily via serotonin 2A and serotonin 2C receptors. So if on one end we boost serotonin transmission and on the other end we monitor what is happening with prolactin, we can assess if there are differences between healthy individuals and depressed patients in their serotoninergic transmission. In addition to that, we can also sound out norepinephrine system. So clonidine is an alpha-2 agonist. So it acts directly on alpha-2 norepinephrine receptors. And there's a consequence to activation of these noradrenergic receptors, and that is regulation of growth hormone release. So if we utilize clonidine and measure changes in growth hormones in individuals who have depression, we'll have a better sense of how their norepinephrine transmission is overall, at least in terms of sensitivity of alpha-2 receptors, which are adaptable. And again, using these indirect and admittedly somewhat rough measures, we come to this conclusion. So looking at individuals who have norepinephrine abnormality alone, or dual norepinephrine and serotonin abnormality, and if we group them all together, this is what we find out. Only about half of our depressed patients will have some norepinephrine abnormality, be it in isolation or in combination with serotonin. How about serotonin system? So looking again at individuals who have abnormal serotonin transmission measured this way, or combined with serotonin or epinephrine, the outcome is that about 30 patients will have some serotonergic abnormality. But the part that is particularly intriguing is about 40% of MDD patients did not demonstrate any norepinephrine or serotonin-based abnormality in transmission. So 40%, which is quite intriguing because looking at the response rates with monoamine modulating antidepressants and remission, and there's pretty clear evidence that about 40% of them are not doing well with monoamine modulating antidepressants, no matter what we do and what kind of combinations of medicines we use. So if it's not all about serotonin and norepinephrine, and let's add dopamine to that list, what is really going on in depression? Well, let us start with by repeating the statement that we have made, and that is that major depressive disorder biologically is a heterogeneous condition. Therefore, what we're looking for is some commonality. So if there is a hardcore to major depressive disorder, what would be in this hardcore of MDD? How would we go about that? Well, let us use the method of cross-referencing. This is something that works for us when we're doing library searches. Except this time, they took a large number of individuals who have MDD and had functional and structural scanning. Brain tissue was taken from brain banks and cytology was done. Finally, a large pool of genetic data of patients who suffer from major depressive disorders versus controls was added into this mix. Let's shake it all up and look where strong correlations lie. And here is when the dust settled, what appeared to be truth shared by a core of patients suffering from major depressive disorder. Again, this otherwise neurobiologically diverse group. Number one, cellular abnormality was dysfunction of somatostatin expressing GABA interneurons. So this is the most consistent finding. Something with somatostatin expressing GABA interneurons in the brain is off. Number two, when we are talking about cells, astrocytes are not functioning very well. Number three, pyramidal glutamate releasing neurons in the cortex are not functioning appropriately. And number four, there's something wrong with microglia. So if we think about it, we're using medicines to manipulate monoamines to treat depression, where the fault seems to be with GABA interneurons and glutamate neurons, but also two other kinds of cells in the brain, astroglia and microglia. And they're really only indirectly targeted with current pharmacologic approaches. So we are not close to bullseye in terms of our interventions in depression. And the question is, could we have more precise, more direct interventions? And in the rest of our conversation, we'll try to address that question. So things have changed. Thinking about our understanding of neurobiology of MDD and our pharmacologic approaches, it is like ancient sailors crossing the equator, looking at the night sky, and much to their distress, recognizing that North Star is gone. So what they were using to orient themselves, norepinephrine and serotonin, they're no longer there. So what has replaced them? What can we use to navigate? Well, sailors' answer would be Southern Cross. Let us look at what might be equivalents of Southern Cross in terms of our neurobiological understanding and pharmacological understanding of treatment of depression? Well, we have already pointed out on a couple of occasions that major depressive disorder is a heterogeneous condition, yet there may be some commonalities. In terms of neurobiology and areas of the brain that are involved, we do have an understanding that cortical areas which exert so-called top-down regulation of limbic areas are not performing well. And therefore, major depressive disorder will be associated with psychomotor symptoms. Again, this is part of so-called sensory motor or somatomotor network in the brain. It does have a cortical location, psychomotor retardation. Cognitive executive areas are not working well. There's problem with cognition. And then due to lack of top-down regulation, there is increase in negative emotion and anxiety experienced by our depressed patients. But depression does not only reside in the brain. Depression is a mind-body phenomenon. So when things are not going well in the brain has a way of activating a defensive repertoire. And this defensive repertoire has been developed and fine-tuned through millennia of human existence. So it is to prepare us for states of emergency where we are under attack, for fight or flight response, if you will. So what are some of the components of that fight or flight response? Well, there will be increased activity in hypothalamic pituitary adrenal axis. The purpose of evolutionary purpose of HPA activation is more cortisol, and cortisol will increase circulating glucose levels, sugar levels, which is needed as energy source to help us escape this danger. There will be change in balance between sympathetic and parasympathetic activity, more sympathetic activation, less parasympathetic activation, because frankly, parasympathetic functions such as digestion, elimination, or sexual activity are not priorities if we're fighting for our survival. And therefore, blood is redistributed to our brain, heart, and muscles. That is where we need it if we're trying to escape or fight. And finally, immune activation. Doesn't make sense that if you're having a fight with your coworkers or spouse that you would be activating your immune system, but you do. And the same thing happens in many patients who suffer from major depressive disorder. Why? Again, we have to look at it through evolutionary lens. And if we are in a dangerous situation, there's a good chance that our body's integrity will be disrupted and that our wounds may get infected. And therefore, ramping out immune response is associated with greater chance of survival. These mechanisms that have been developed millennia ago still function and are activated in the course of depression. Well, of course, with increased inflammatory signaling in the periphery, these signals eventually do reach the brain. And when they reach the brain, what are some of the correlates? Well, correlates are disruption in GABA-glutamate balance signaling in the brain. They're associated with compromised monoamine transmission. So our monoamine transmission in the brain can be altered because there is peripheral inflammation. And finally, there appears to be suppression of neuroplasticity. So nerve growth factors are compromised. So as you can see, we don't need to look at depression as a brain disease. It is maybe more fruitful to have this integrated approach where we look at it as mind-body dysfunction. So I have mentioned briefly networks in the brain. This will be a little bit more detailed discussion, which will be necessary to understand how some of these future medications may be working. So I'm going to address just 3 principal brain networks. It is their dysfunction that maps onto the symptoms of depression most readily. So it's not a epinephrine or dopamine or serotonin scenario, nor frankly, just plain GABA and glutamate. It is this function of these functional networks that translates into symptoms of depression. So how might that be? Well, let us start one by one. First, so-called Salience Network. Salience Network receives as raw input all of the sensory information informing us about any change, be in our external or our internal environment. Hubs, the main parts of this Salience Network, include anterior cingulate cortex and insula. They again also received information from thalamus that is filtered through, and basal ganglia, it's all filtered in. So the main purpose of Salience Network is to translate sensations into emotions, which will then drive our adaptive behavior. If there is some kind of a danger looming, or if we are infected, or if we have stomach ache, or if we have some acute pain, all of that will translate into certain kind of emotional change, which will drive adaptive behaviors. So what will organize these adaptive behaviors? That is, some people call it central executive network. Some people call it cognitive executive network. Some people call it attentional or frontoparietal network. In essence, there's more similarity than difference. So the hubs of cognitive executive network will be dorsolateral prefrontal cortex and posterior parietal cortices. What is their role? Their role is when something important has happened in our environment, we need to reallocate our attentional focus. So instead of reminiscing about our last year's vacation, or what are we going to do during the weekend, or what do we have in the fridge? Do we need to get something for dinner? This all is part of the working of default mode network, which I'll bring up in just a few minutes. We are more looking at how do we problem solve? What do we do about something that is an imminent threat? So reallocating our focus, storing the relevant information in working memory, organizing our behavioral response. This is all cognitive executive network. In collaboration with Salience Network, which is giving us a signal that we need to do something about an important change in our internal or external environment. And then finally, there is so-called default mode network. And default mode network is engaged when we're off task. So if we're planning or self-reflecting or reminiscing or processing social information or engaged in creative writing or composing music, it is default mode network that is active. What are some of the principal components of default mode network? Well, default mode network includes so-called midline structures in the brain. So dorsomedial prefrontal cortex, ventromedial prefrontal cortex, posterior cingulate, and one includes hippocampus, often in the workings of default mode network. That is the composition of this important network. So what is happening when it comes to communication between these networks in individuals who are depressed? Now, we have a lot of functional imaging studies that give us a pretty good clue. So some networks are inappropriately strongly connected, and some appear to be connected less than they should be. So let's start first with what are the networks that are connected less than they should be. It is Salience Network and Cognitive Executive Network. What are some of the clinical ramifications of this? Well, we are under-responsive when we're depressed to environmental cues. So our volition is at a low point. People are not very motivated. Depressed patients will tell you, so many things I need to do, I just can't get myself to do it. Their cognition will be disturbed, absolutely. Their ability to enjoy life, reward areas are intimately connected to Salience Network. Life is not enjoyable. I feel emotionally flat. I feel emotionally drained. These are all the complaints that we hear from depressed patients, most likely associated with inadequate function of the Salience Network and its connection to cognitive executive network. People feel paralyzed and they feel helpless. Also, so-called top-down regulation of emotion is not working very well. We could not bear our cognitions and our coping mechanisms to bear on improving our predicament. Some neuroscientists call this kind of a locked-in syndrome, in that patients who are depressed are locked into themselves. Part of being locked into themselves is this hot wiring between Salience Network and default mode network. So Salience Network is generating all these negative emotions. I'm feeling sad. I'm feeling dejected. I'm feeling irritable. I'm feeling anxious. I'm feeling hopeless. And then the flow of this negative emotion engages default mode network, and it becomes elaborated. We see that Rolodex of misery is now on the spin cycle, and depressed patients are ruminating. They're thinking about all the things that have gone bad in their life. And again, default mode network has also a forward-facing perspective. Not only have things gone bad in my past, most likely things will go bad in my future. This is where some of the pessimism that is part of depression may be coming from. So depressed patients are predominantly inwardly oriented, elaborating all these negative emotions and associated thoughts. And they are less capable in looking outward and thinking about what can I do to change my environment. That is the sad nature of major depressive disorder. In majority of the patients, this seems to be commonplace. So if it is that these brain networks don't communicate with each other very well, what are the cables that connect them? Well, surprisingly, the cables that connect them have nothing to do with norepinephrine, serotonin, and dopamine. Those are GABA and glutamate fibers. So first order neurobiological evidence suggesting something's wrong with GABA and glutamate. Something's wrong with the function of functional networks. And here we see that connections between components of these functional networks are made by GABA and glutamate. So should this be focus of our pharmacologic approaches? Do we need more evidence? Well, here it is. Patients, or actually these are healthy controls, in some instances patients too, are performing a task of emotional regulation. So this is a very simple psychological paradigm. One is trying to suppress negative feelings. What is becoming activated? What is becoming activated is anterior cingulate. So this is kind of a focal point where many of these networks cross roads. What are the neurotransmitters that are involved in emotional regulation? They're GABA and glutamate, you've guessed it. What do norepinephrine, serotonin, and dopamine regulate in the prefrontal cortices and in limbic areas? Balance between GABA and glutamate. That is where their receptors are, right? So we may be looking at the same thing from a different perspective. Now, do we know that there's something abnormal in these areas? There is no radioligand that is called SV2A. And SV2A can give us an insight into synaptic density in some of these key brain areas. So what is the actual communication in these key brain areas? So we're looking at dorsolateral prefrontal cortex, again, one of the hubs of cognitive executive network, also top-down regulation of emotion, anterior cingulate, crossroads between all these functional networks, and hippocampus, which is not only involved in declarative memory and spatial memory and endocrine regulation, it is also part of default mode network. And here is the finding. The more decreased synaptic density in these key areas belonging to three major networks, so the lesser synaptic density, the more depressed people are, measured by Hamilton Depression Scale 17-item version. So there's a direct correlation between decreased synaptic density in these key brain areas and depression scores. So it seems that we're zooming on onto something that is really important to us. And I mentioned also some of the bodily manifestations of major depressive disorder. Let us look at how they play out in the brain. So when these inflammatory signals via multiple translations, I will not get into that fine-grained detail, reach the brain, what happens? Well, the primary recipients of these inflammatory signals, along with some of the lymphocytes, which in situation of increased peripheral inflammation, are able to seep into the brain, pass through blood-brain barrier, which is otherwise an impermeable barrier to them. But in situation of inflammation or chronic stress, they can actually enter the brain. And they activate resident immune cells, which are microglia cells. And they will also influence astrocytes. So what happens is that both microglia and astrocytes change their morphology and function. So they go through metamorphosis and they turn into pro-inflammatory cells in the brain. Microglia cells, which are the major producers, you've heard of BDNF, brain-derived neurotrophic factor. Major producer of BDNF in the brain are microglia cells. They're not neurons, they're microglia cells. And then it's astrocyte, and then it's neurons. So all of a sudden, their production capacity is diverted, and they're no longer making neurotrophic factors. What are they producing instead? Inflammatory cytokines. Interleukin-1, interleukin-6, tumor necrosis factor alpha. They're also releasing reactive oxygen and nitrogen species, which also perpetuate inflammation. Well, this kind of negative conversation between astroglia and microglia has significant impact on the function of astrocytes. Why is that important to us? Because you see astrocytes, they are not really green. In this picture, they are green, have these extensions, which work pretty much like joint capsules. Think about a knee joint, which is encapsulated. So astroglia encapsulate synapses. And they do a lot of things to make sure that synapses work well. So when there is ion disbalance due to increased activity and action potentials in the synapse, additional ions are going to be soaked up by astrocytes. They act as a sink, they pull them out, so that balance in firing can be reestablished. There's too much neurotransmitter. Astrocytes said, not a problem, we have pumps. We will pump out surplus glutamate, so signal to noise ratio is maintained. It's a very busy synapse. It needs more energy to function. Astrocytes said, we got that. They start releasing lactate, amongst other things, as an additional source of energy for highly functioning synapses. Astrocytes also have receptors to norepinephrine, serotonin, dopamine. So they're the cells that do a lot of analog processing. Nerve cells either fire or they don't. So they're very much binary elements. So analog processing is really important, conducted by astrocytes for good function of the brain. As a matter of fact, astrocyte numbers seem to be correlated with IQ in people. They are the gatekeepers. Neurons live in gated communities. A lot of things are done for them. So when astrocytes start malfunctioning, if this is a glutamatergic synapse, what happens is glutamate is spilled out of the synapse, and it starts attaching itself to these extrasynaptic NMDA receptors, which should not be available to them under physiological circumstances. Why is that important to us? Because activation of extrasynaptic NMDA receptors results in suppression of neuroplasticity. So microglia are impaired, astrocytes are impaired, extrasynaptic NMDA receptors are activated, all together resulting in decreased neuroplasticity. Remember, we just saw a slide indicating that decreased synaptic density is associated with intensity of depression in these key brain areas, such as dorsal prefrontal cortex, hippocampus, and anterior cingulate. Furthermore, if there is decreased neurotrophic signaling and increased inflammation, which we see as the case, it impacts on the function of oligodendroglia. Oligodendroglia, by creating myelin sheets, pave this freeway system in the brain, if you will, these long connections between key brain areas involved in these networks. So all of a sudden, we're dealing with impaired roads. They have a lot of potholes, and therefore communication between these hubs in functional networks becomes compromised. So again, when bodily inflammation comes in the mix, what are some of the immediate consequences? Disruption of GABA-glutamate balance, suppression of neuroplasticity, increase in inflammatory signaling. An increase in inflammatory signaling translates into disruption of monoamine signaling. And then the connections between the hubs, because of dysfunction of oligodendroglia, is compromised. So depression has generated all these bodily repercussions, and some of the chemicals that come from these peripheral consequences of depression feed back to the brain and attack the most vulnerable elements of neural functioning. So you see how it is all integrated and how it all works together. But let's not forget, it's not only nerve cells, GABA interneurons, and glutamatergic pyramidal neurons in the prefrontal cortex. It's also astroglia cells and microglia cells. And I will have some news for you about these cells, a different view of these cells in just a minute. I mentioned that a deeper analysis into what astrocytes are will yield some surprises. So more recently, neuroscientists in British Columbia in Canada attempted to map a little bit more about cellular function, the cellular functions associated with astrocytes. And here's what they found out. When it comes to enzymes that are involved in synthesis of GABA, and also enzymes that are involved in degradation of GABA neurotransmitter, astrocytes have both. So this came as a little bit of a surprise to us. Half of GABA-producing cells in the brain are not nerve cells, they're astrocytes. Another surprise, we have spoken about how inflammatory signal activate astrocytes and microglia. So let us see what happens, if you wouldn't mind focusing your attention on the right side of the slide. So if we rile up microglia and astrocytes by injecting, this is a cell culture, this is in vitro study. If we rile them up by providing lipopolysaccharides, that is the stimulus, it's marked here as ST, stimulator of inflammation, we will see that it will result in greatly increased production of inflammatory cytokines, so tumor necrosis factor alpha in interleukin-6. So you rile up microglia and astroglia, and they start producing these inflammatory cytokines. Now, what happens if you add GABA into the mix? If you add GABA into the mix, you will see that it will dramatically suppress synthesis of inflammatory cytokines in microglia and astrocytes. So GABA is not only an inhibitory neurotransmitter when it comes to its neural function, it's also inhibitor of inflammatory cytokine synthesis in microglia and astroglia. In other words, GABA glutamate are yin and yang of neurotransmission. GABA and glutamate are yin and yang of inflammatory signaling in the brain as well. And there is some further proof to that. So now we're looking at microglia cells. I mentioned that they transform. They stop producing neurotrophic factors and increase producing inflammatory cytokines. How is that regulated? Well, norepinephrine and dopamine calm down microglia, calm down, generally speaking, their inflammatory signaling. Acetylcholine via nicotinic receptors calms down microglia. GABA calms down microglia. What jazzes them up and makes them pro-inflammatory? Glutamate via NMDA receptors, serotonin via serotonin 2A and serotonin 7 receptors. What else can calm them down? Interleukin 10, an inflammatory cytokine. So their fractalkine can calm them down. So there are multiple substances which all converge on microglia. And please understand, when we manipulate serotonin, dopamine, norepinephrine, and their receptors, we're also influencing not only neural cells, but we're influencing astroglia, we're influencing microglia. It's a much more complex system than we previously believed. So manipulating monoamines GABA-glutamate balance can in some ways normalize inflammatory signaling in the brain as well as microglia and astroglia function. Now let us examine more closely glutamatergic treatments. So is glutamate transmission disturbed in the brain of depressed individuals? I will share with you some of the evidence. So this is now ventromedial prefrontal cortex. Ventromedial prefrontal cortex is not only part of so-called default mode network. It's part of the brain that feeds to brainstem and regulates monoamine transmission. So if something is impaired with glutamate transmission in ventromedial prefrontal cortex, monoamine transmission will suffer. What do we know about glutamate transmission in ventromedial prefrontal cortex in depressed individuals? In early phases of disease, so this is in individuals who are having their first depressive episode. How does it compare to controls? Not much difference. How about patients who are having recurrent depression, even if they're currently euthymic, or they have chronic depression? Substantial reduction in glutamate signaling. So it appears that repeated episodes and chronic depression are associated with compromised glutamate transmission in this key component of top-down regulation of emotion, ventromedial prefrontal cortex, part of the brain that regulates how monoamine nuclei and brainstem work. It is compromised. And what we're seeing is that the longer depression lasts, the more compromised glutamate signaling is. So you're looking at now the right side of the slide, duration of illness versus glutamate concentration in ventromedial prefrontal cortex. The longer depression lasts, the more compromised glutamate transmission is. Which brings us to a really interesting point. Now that we have one and will soon have a couple of different glutamate modulating agents, when should we really start using them? Should we wait until late in the course and then use them? Or should we get some of our star players off the bench and into the game earlier? Now, unfortunately, our practice is influenced not only by science, which I must admit is still lacking, but also societal factors such as what will insurance companies support? And in my understanding, insurance companies don't have the most accurate understanding of neurobiology of MDD, but yet they influence our treatment choices in a very significant way. So I'm sorry, I didn't mean to get on the pulpit about this, but you do realize that there's a big question: should there be a phase-specific treatment of MDD? And should we be making some of these interventions earlier in the course than we do? We've spoken about anterior cingulate. What a key component in all these networks, ACC, anterior cingulate, is. And what we're finding here, again, a very sophisticated study, there is a difference between healthy controls and unipolar depression in terms of glutamate signaling. So there is decreased concentration of glutamate in depressed individuals relative to controls. So we have seen compromised glutamate signaling in ventromedial prefrontal cortex. Now we're seeing in this key crossroads, anterior cingulate, compromised glutamate signaling in depressed patients. Let's go further. Hippocampus, which again regulates endocrine function, is involved in short-term memory, in declarative memory, in spatial memory. It is also part of default mode network. What's going on there? Decreased glutamate signaling. In which patients? In the ones who have recurrent depression and in the ones who have chronic depression. The same pattern in these key areas of the brain when it comes to major functional networks and regulation of emotion stress response. And we see that there's not only diminished glutamate signaling, but if we look at the indicator of cellular integrity, and this is N-acetyl-aspartate, both right and left, hippocampus, we see that in parallel with decreased glutamate function, there is an alarming sign that cellular integrity of glutamate neurons in this part of the brain is disrupted. So, especially in chronic and recurrent depression, that is where we have a signal that glutamate transmission in these key brain areas is off. So how might we intervene? Well, I mentioned that there are medications that have an impact on glutamatergic transmission that are currently approved by FDA and some that are in usage, but not. So what is approved by FDA for treatment of two scenarios: treatment-resistant MDD and also major depressive disorder that is not necessarily treatment-resistant, but is associated with suicidal ideation. So the compound I'm speaking about is esketamine. The compound that is indicated as anesthetic, but not for treatment of MDD, is ketamine racemic mix. So it is being used, whatever we think about it is in usage. When one thing that is good to know about these NMDA receptor antagonists, although they're antagonists of NMDA receptor, their ultimate function is to increase glutamate transmission. We'll in a second explain how it goes. The other thing that is worth pointing out, they don't work equally well on all NMDA receptors. They have particular affinity for NMDA receptors that have so-called N2B subunit. And those are extrasynaptic NMDA receptors. So both ketamine and esketamine primarily modulate extrasynaptic NMDA receptors. Well, if they're outside the synapse, where in the world are they? Well, some of them are on GABA interneurons. So glutamate via NMDA receptors on GABA interneurons drives GABA signaling. And what does GABA do? It inhibits. So when NMDA-mediated transmission drives GABA, it releases GABA, which inhibits glutamate transmission. Therefore, when you inhibit these NMDA receptors on GABA interneurons, the outcome is you disinhibit glutamate transmission. And that is how NMDA inhibitors in actuality increase the output of glutamate neurons. Now, if this output is there, where does it go? Well, some of it goes to intrasynaptic NMDA and AMPA receptors. their activation increases neuroplasticity and synthesis of neurotrophic factors. So that is a good thing. But on the other side, we've seen that there's astroglial dysfunction, and the glutamate spills outside the synapse and activates these extrasynaptic NMDA receptors, which impede synthesis of neurotrophic factors. Another place where we have good news, S-ketamine and ketamine inhibit these extrasynaptic NMDA receptors, therefore diminish suppression of neuroplasticity. So two mechanisms by which they increase neuroplasticity and synaptogenesis, and two mechanisms by which they increase glutamate signaling. And you have seen that there are deficiencies in glutamate signaling in individuals who have recurrent and chronic forms of major depressive disorder. Something else that is relatively new finding, it does have to do with glutamate signaling. It involves a structure that is in epithalamus. So it's the sides of the third ventricle. It's called lateral habenula. What is going on with lateral habenula? Lateral habenula is misery generator in the brain. There's no polite way to say it. Activation of lateral habenula generates negative emotional states. And as you can see here, it suppresses dopamine and serotonin transmission. NMDA antagonist, and this is extrasynaptic NMDA antagonists such as S-ketamine and ketamine, directly suppress burst firing from habenula. And this may be one of the best explanations for the rapid onset of antidepressant agents in with these agents. Again, they suppress the misery generator very, very rapidly. How about all these functional networks that we have spent so much time talking about? What happens with them after use of ketamine and presumably S-ketamine, although the imaging studies were done with ketamine? Well, those are attentional network and components of cognitive executive network come back online. So cognition is hypothetically restored, improved. And with that top-down regulation of negative emotions. What happens with default mode network, the one that was in this negative ruminative spin cycle in individuals who have major depressive disorder, it is suppressed. So usage of S-ketamine and ketamine at neurobiological level, early evidence would suggest increases cognitive executive network function, including top-down regulation of emotion, and suppresses the function of default mode network that may be associated with these negative ruminations. It also suppresses lateral habenula firing, which is associated with misery generation, right? So a lot of good things seem to be happening, both at the cellular and functional network level. Now, what does the clinical evidence look like? Well, it's really interesting because adjunctive intranasal S-ketamine was used in patients who have treatment-resistant depression. So they have documented failure of two antidepressants. So this would be equivalent to step 3 in STAR-D. And what were remission rates in step 3? They're about 14, 15%. What are remission rates associated with S-ketamine intranasal? In this particular acute study, it was given twice a week. So there were 8 administrations over the course of a month. The outcome is remission rate of 52%. So roughly 3-fold what was seen in step 3 in STAR-D. Now again, these are apples to oranges. There's no question about that. The study design, protocol are very, very different. Yet we can't also help but conclude these are very encouraging findings. The other part that is important, remember step 2, for 45% of the patients, it took more than 9 weeks to get a response. When was response evident with S-ketamine? First day, within a matter of hours. Now, for the response to be stabilized and to progress, it took a bit more time. You needed several administrations of S-ketamine. That is what I've seen with my patients. They will report that the first time they receive ketamine, if they're indeed responding, not everybody does, but many do, their mood improves within hours, but gradually starts declining between the treatments. After a handful of treatments, these gains seem to be more consolidated, which, if we believe, this is all very hypothetical, that there is activation of neuroplasticity, it would make sense that these neuroplastic changes will take a little bit longer to be consolidated. So in essence, it kind of reroutes neurotransmission. The pattern of activity in the brain may be changed. Which brings us to, well, do we have long-term data? And with ketamine, racemic ketamine mix, it's a little bit more sketchy. There's not a whole lot of long-term control literature, but with S-ketamine intranasal, there is. So in individuals who achieved remission, S-ketamine was administered just twice a month. In individuals who were responders but didn't remit, S-ketamine was administered weekly. And what is the long-term outcome? In remitters who received 2 administrations of S-ketamine in a month, it resulted in 51% reduction in relapse rate. What if they were responders but not remitters and they received S-ketamine weekly? The outcome was that there was 70% reduction in relapse rate. So these are indeed very encouraging numbers, again, suggesting that there's some complementarity. These individuals were receiving a new antidepressant, an SSRI and SNRI, but in addition to that, glutamatergic intervention. And this kind of combination produced much better, much more encouraging numbers, indicating that possibly these individuals have another mechanism of disease that was beyond direct involvement of monoamides. What are some of the adverse reactions that have been encountered in this long-term study? Well, change in taste, a little bit of bitter taste, vertigo, somnolence, dissociation, sedation. Most of these adverse reactions were self-contained, lasted for just a couple of hours, and then fairly rapidly dissipated. Is there evidence in meta-analysis, this is now racemic ketamine, compared to control? So this is sub-analysis of only control studies. It's not easy to control S-ketamine and ketamine with placebo for a very simple reason. If our patients are dissociating and sedated on placebo, they have other issues we need to be concerned by. So sometimes midazolam, it is generic name for benzodiazepine, also known as Versed, which is used for rapid sedation. It's used with endoscopic intervention and brief surgical interventions. That will cause changes in sensorium, and therefore it is often used as a control. Be it as it may, in acute setting, so we are talking 1 day. When it comes to odds ratio of responding to ketamine versus control, tenfold in favor of ketamine. This is not what we see in monoamine modulating antidepressants, where it's about 25% remission rate on placebo, 35 on an antidepressant. So there's maybe 40% difference. Here, it is tenfold difference day 1. At the end of the first week, it's about 5-fold difference. So suggesting that, again, in some patients, that this may be much more direct path to treatment of depression. Impact of S-ketamine and ketamine on suicidal ideation. We see a clinician-administered measures. So these are items on MADRS scale, Montgomery-Åsberg Depression Rating Scale. Item 10 reflects suicidality. And self-reported based on QIDS, Quick Inventory of Depressive Symptoms. Item 12, again, reflecting suicidality. Whether it's clinician-reported or self-reported, about 60% suppression of suicidal ideation at the end of day 1. This suppression of suicidal ideation continues through days 2 and 3. So there is significant reduction. With time, controls catch up. But as you know, if you're trying to deal with suicidal ideation, suppressing it for 3 days is clinically very important. Looking at overall impact on some symptom domains of esketamine, let us look at the most staunch symptoms of depression, and they belong to so-called anhedonia subscale. There are 4 elements there. Inability to feel is one of those. Lassitude, passivity is another. Concentration is another, and apparent sadness. So those are the 4 elements. Look at the improvement, rapid improvement with racemic ketamine when it comes to inability to feel, lassitude, apparent sadness, and concentration. Dramatic reduction in all these symptoms, almost 50%, rapidly. So again, this is a little bit different approach to treatment of depression. So when it comes to anti-suicidal effect of these medicines, there are early indicators, but early indicators do not allow us to make any far-reaching conclusions. So at least within few hours and maybe a couple of days after infusion or administration, it seems to be associated with reduction in suicidal ideation, both objectively and subjectively measured. A reminder that intranasal esketamine is approved in MDD patients who have suicidal ideation or behavior, but is not approved for suppression of suicidality. It is approved for reduction in depression, in depressive symptomatology. And we do need future research to better qualify the impact of esketamine and racemic ketamine in potential treatment of suicidality. So if we're comparing esketamine and ketamine, what do we know? Are there any bottom lines where there's, right now, there are so many studies and reports coming out, and it is beyond esketamine intranasal, it is ketamine intravenous, it is ketamine oral, it is ketamine subcutaneous, it is ketamine intramuscular. Honestly, it is really hard to sift through these data. Bottom line, ongoing maintenance evidence for racemic ketamine is lacking. There's some evidence, but this is not very robust. Esketamine is FDA approved, and we do have long-term studies that look quite encouraging. So now let us look at some novel glutamate modulating treatments. We have mentioned that ketamine and esketamine block extrasynaptic NMDA receptors on GABA interneurons and therefore disinhibit glutamate transmission. Very similar mechanism of action if we use scopolamine. Scopolamine is muscarinic 1 receptor antagonist. So much like glutamate, revving up GABA interneurons, acetylcholine via muscarinic receptors does the same thing. So if we block M1, extrasynaptic receptors, which would be achieved by scopolamine on GABA interneurons, as a result, we may have indirect increase in glutamate transmission. And indeed, there are some preliminary data suggesting that scopolamine may accelerate antidepressant response. There are few published studies, literally 2 or 3, suggesting its efficacy in depression, but to my knowledge, this compound is no longer being developed for treatment of depression. Something that may be on a near horizon in that combination of dextromethorphan and bupropion is being currently reviewed by FDA. The phase 3 studies have been completed, and we don't know what the final word will be. We're still waiting to hear what the FDA response will be. But what does dextromethorphan do? Well, dextromethorphan is also an NMDA. So this is the same dextromethorphan that is in the cough syrup, albeit at very different doses. So dextromethorphan is an NMDA receptor antagonist, but it also modulates sigma-1 receptors. And sigma-1 receptors do 2 things. They're involved in trafficking of components of NMDA and AMPA receptors. So they may actually increase indirectly glutamate signaling via AMPA receptors. And sigma-1 are also involved in regulation of synthesis and function of neurotrophic factors, such as nerve growth factor and BDNF, brain-derived neurotrophic factors. What is the clinical evidence? We're looking at some of the studies that have been submitted to FDA. The dosage of dextromethorphan is 45 milligrams combined with 105 milligrams of bupropion, which, as you know, is norepinephrine dopamine reuptake inhibiting agent. Why were they combined? Because dextromethorphan has very short half-life, just a few hours. And it would be very hard to achieve pharmacologic action unless we inhibit its metabolism. And that is one of the roles of bupropion, to slow down its metabolism and therefore improve its pharmacokinetic profile. So we see that this combination, 45 milligrams of dextromethorphan and bupropion administered on BID basis, translate into relatively rapid reduction in depressive symptomatology, reaching statistical significance already first week, maintained and increasing in its separation from placebo as the time went on. This was a 6-week study. The outcome that we're looking here is MADRS, Montgomery-Åsberg Depression Rating Scale. So this is a clinician-rated instrument. And there is also evidence from QIDS, Quick Inventory of Depressive Symptoms, self-rated 16-item scale, that patients are also seeing improvement that is also rapid with this combination of NMDA antagonist, sigma-1 modulating, and mild SSRI relative to placebo. How about psychedelics? You've heard a lot about psychedelics. Unless you were on an extended vacation during COVID era, you have definitely seen something in the news or read articles about psychedelics. What are psychedelics? They're serotonin 2A agonists. Where are these serotonin 2A receptors? When many of them are on pyramidal glutamatergic neurons in deep cortical layers. Stimulation of serotonin 2A receptors will increase glutamate output. And then we have synergy. These deep layer pyramidal neurons communicate with pyramidal neurons in layer 5, so even deeper. So we have combined increased glutamate output and stimulation of serotonin 2A receptors on these pyramidal neurons. So it's now amplified, which result in increase in glutamatergic transmission. So in some ways, it is a serotonin 2A mediated increase in glutamatergic function. Now, depression scales may not adequately capture what happens with psychedelics. And psychedelics are usually sandwiched between sessions of psychotherapy. Administration of psychedelic with supportive therapy going on while the administration is actively taking place. It's usually an 8-hour session, and there are usually a couple of administrations in the protocol, is associated with changes that are not necessarily reflected on depression scales. So patients experience this sense of unity with the universe and have intense spiritual experiences and blissful state and increase in insight. These are not the items that are present on usual depression scales, and therefore benefits of these medications and creating openness and different experience in psychotherapy is again not something that is easily evaluated using conventional scales and instruments. What we do know in terms of biological correlates, that improvement in depression associated with psilocybin, one of the psychedelic medication, is associated with suppression in amygdala activity. And we know that increased amygdala activity is associated with intensity of depression in some of the studies and also with the anxiety. So psilocybin may reduce amygdala activity, and there are some controlled studies. This one has essentially weightless control. And we do see that psilocybin administration, 20 and 30 milligrams per 70 kilos, was associated with very substantial reduction in depressed scores, both at week 1 and at week 4. Does it last? Unfortunately, we don't have a whole lot of data. This is a paper published by Rob and Carhart Harris, and we see that the effect of psilocybin stimulants was noticeable as far as 6 months after initial administrations. Effect size is very robust, but please keep in mind that this is not effect size that measures separation from placebo because there was no placebo. It is separation from baseline. And it does seem to decay after about 3 to 4 weeks. Finally, is there some kind of unified field theory about glutamatergic interventions that provides explanation for some neuromodulatory treatments as well? Well, yes, there is. By using catecholamine boosting agents, so norepinephrine and dopamine boosting treatments, we increase activity in cognitive executive network. When I say increase activity, it doesn't mean boost up. What it means is essentially better signal to noise ratio. So norepinephrine and dopamine boosting agents don't create excitement. They change signal to noise ratio. It would be akin to kids in the back seat screaming and fighting and loudly arguing so that parents can't hear each other in the front seat, and then parent would turn around and say, shh, decrease noise in order to improve signal to noise ratio. Dopamine, norepinephrine in the prefrontal cortex. Shh, that is what they do. Also, TMS, this is at least our understanding. Repeated transcranial magnetic stimulation increases the activity in dorsolateral prefrontal cortex, top-down regulation of emotion, possibly improvement in cognition. So some synergy with catecholamine boosting treatments. And then glutamatergic agents also increase the function in cognitive executive network, as you have seen in the imaging studies, but some indirectly, some directly also suppress negative emotion in limbic areas. So there is convergence of data. There is information that is connecting all these diverse mechanisms of action. Finally, we'll have a brief review of what GABA modulating agents may do. So first of all, when we say GABA, people immediately start thinking about benzodiazepines. Well, where naturally occurring neurosteroids bind on GABA receptor and where benzos bind are two different places. So what are these neurosteroids? Are they really steroids? No, they have nothing to do with steroid hormones. The reason they're neuro is because they're synthesized in neural tissue, predominantly by glutamatergic neurons. Astrocytes also have a role in synthesis of neurosteroids. Why in the world are we calling them steroids? Because cholesterol ring is part of their chemical formula. So again, don't think about them as corticosteroids, not really much relevance at all. Neural tissue synthesized compounds that have cholesterol ring in its chemical formula. But what do they actually do? They modulate GABA-A receptors. So this is a GABAergic intervention. While benzodiazepines will bind in the vicinity of alpha-2, 3 subunits of GABA receptor, close to gamma-2 unit, in normal circumstances, they will enhance GABA transmission. Neurosteroids here as red triangles do the same thing, but they bind in a different place. Now, part that is interesting, during protracted stress, which is neurobiologically similar to situation in depression based on preclinical animal models, something interesting happens. And that is configuration of intrasynaptic GABA-A receptor changes. And this new configuration is less amenable to benzos. Benzos don't bind as readily. On the other hand, it enhances binding of neurosteroids. So neurosteroids really get going in these kind of depressive and chronic stress-related situations, at least based on preclinical data. Something else that is not done by benzos and is done by neurosteroids has to do with extrasynaptic, this time not NMDA, but extrasynaptic GABA-A receptors. So these are regulators of baseline GABA transmission. These are regulators of baseline ratio of excitation to inhibition, which we have seen is disrupted in major depressive disorder. GABA does not regulate this at all. GABA does not bind. I'm sorry, not GABA. Benzodiazepines do not bind to extrasynaptic GABA receptors. Neurosteroids do. So neurosteroids are regulators of tonic GABA signaling. Benzos are not. They will regulate intrasynaptic phasic GABA signaling, and only in circumstances that are not associated with depression and chronic stress. They do have a function there. It's a little bit more muted, though. And here we see a graph recapitulating that. So when it comes to tonic regulation, neurosteroids do it. Benzos do to a degree, not as much in face of chronic stress. But when it comes to, phasic inhibition, so intrasynaptic inhibition, benzos do to a degree, neurosteroids do. But when it comes to tonic regulation of GABA-A receptors, neurosteroids do, benzos don't. Now, why are we so interested all of a sudden in GABA interneurons? Remember, that was number one finding. Number one, cellular commonality in individuals who are depressed. Now, I mentioned somatostatin expressing. Why? Because there are many subtypes of GABA interneurons. Only some of them will express somatostatin, some of them will express parvalbumin, some of them will express serotonin 3 receptors, and that is how they're classified. The importance of these somatostatin expressing GABA interneurons is if they are malfunctioning, the outcome is that there will be impaired glutamate transmission. And that is what we see in major depressive disorder. So it could be that some of the impaired glutamate transmission is a consequence of malfunction of somatostatin expressing GABA interneurons. The other part that is really interesting, I've spoken about these monoamine receptors, serotonin, norepinephrine, and dopamine receptors being present on glutamate interneurons. They're also present on GABA interneurons, including somatostatin expressing neurons. So if they're not functioning, glutamate input into brainstem is not good. The outcome, it looks as if serotonin, norepinephrine, and dopamine are not functioning. But this is just the downstream consequence of GABA and glutamate malfunction. A slide that illustrates this in some detail, and also telling us that if glutamate transmission is compromised because somatostatin GABA interneurons are not working, it is glutamatergic input into amygdala, this threat and danger Salience Network part of the brain, thalamus, which regulates sensory input, brainstem nuclei that regulate serotonin, norepinephrine, and dopamine will all be off. So we think about it, what is going on in depression? Limbic areas are not controlled very well. Endocrine balance is not controlled very well. Sensory motor regulation is off. People have psychomotor retardation. Brainstem nuclei would generate norepinephrine, dopamine, and serotonin are not working very well. Is this the cause? Or is this the consequence? That is the big question. And we see that there's this very complex regulation where there's short loop, so serotonin, norepinephrine, and dopamine can regulate their own firing through autoreceptors, but there's also a long loop where they ultimately influence GABA glutamate balance. And if this GABA glutamate balance is disrupted, ventromedial prefrontal cortex regulation of monoamine signaling is inadequate. And it starts looking like there's something wrong with norepinephrine and dopamine and serotonin, which may be secondary, not primary. Do we have any evidence that reduced GABA signaling in ACC, anterior cingulate, this key area of the brain, is in play in depression? Well, it depends. Here is the interesting finding. If you compare GABA signaling here noted as GABA to water ratio in anterior cingulate, in patients who don't have treatment-resistant depression, looks okay. But in patients who have treatment-resistant depression, so these are the ones who are not responding to SSRIs and SNRIs, That is where we see compromised GABA signaling. So this is the cause that lies outside our conventional pharmacologic approaches in MDD. In terms of onset of depression, where do we see the greatest GABA malfunction? In patients who have early onset depression, and they're the ones who typically don't respond so well to modulating antidepressants. And finally, if we're looking at gene expression, regulating GABA signaling, again in ACC, we see that there's big difference, 33% difference in SST expression mRNA in individuals who are depressed versus not. So multiple levels of evidence all implicating GABA transmission in ACC in depressed individuals. It not only correlates with severity of depression, it correlates with anhedonia. So compromised GABA signaling in terms of symptomatic expression may correlate with I'm not enjoying life, I don't have much enthusiasm, I do not have much motivation, I'm emotionally flat. That may be correlated with GABA malfunction in anterior cingulate. We've mentioned hippocampus. We've seen that hippocampal glutamate transmission is compromised in MDD. How about GABA in hippocampus of depressed patients? If they have treatment-resistant depression, there is GABA malfunction in hippocampus. Again, part of the brain that has to do with endocrine regulation, declarative memory, spatial memory, compromised. It's part of default mode network, compromised in treatment-resistant depressed patients, not in the ones who are not treatment-resistant. And it is compromised in individuals who have reduction in hippocampal volume and are depressed. Now, let us look at amygdala. Again, one of the Salience Network parts of the brain involved with negative emotion and anxiety. And again, we see a difference in GABA transmission. More specifically, somatostatin-expressing GABA interneurons in amygdala of depressed patients are different than controls. I mentioned neurosteroids. Our brain makes neurosteroids. Allopregnanolone, which is progesterone derivative, is one of the naturally occurring neurosteroids. Our brain makes them. And what we see is that the greater depression, the lower allopregnanolone presence in the brain. And conversely, increase in allopregnanolone signaling is associated with improvement in depressive symptomatology. How about Hpa Axis? Interestingly enough, if feedback loop functions and high cortisol levels are to suppress CRF firing, and also if we need steroids modulating inflammation, in chronic stress, this is disrupted. There is too much cortisol or inadequate cortisol signaling, CRF is up, there is increased inflammatory signaling. What happens if we introduce neurosteroids? All these normalize. So neurosteroid / GABA function is needed in order to have appropriate immune response and in order to have appropriate HPA response. What else does allopregnanolone do? Well, allopregnanolone is also supporting oligodendroglia functions. So paving of these long pathways in the brain is supported by allopregnanolone and neurosteroids. They are also neuroprotective and they're anti-inflammatory. So all these functions that are compromised in the brain may be supported by neurosteroids and allopregnanolone. Are there any treatments on the horizons? We're looking at zuranolone, which is a synthetic GABA A modulating. This is a positive allosteric modulator of GABA A transmission. It's a different paradigm. Treatment of depression that lasts only for 2 weeks. Measure is baseline to day 15, change in Hamilton Depression Rating Scale scores, and we see robust effect of zuranolone on reducing symptoms of depression compared to placebo within 2 weeks. So again, we're looking at very rapid onset, and it goes on for 2 weeks. In terms of likelihood of achieving remission, day 15, 64% of the patients are in remission in this preliminary control study. So again, patients who are not responding to SSRIs and SNRI, could it be because the problem is with glutamate or GABA A transmission? And if we directly modulate, will we have better outcomes and more prompt outcomes? I think we're beginning to see a pattern here. How about in the long run? This is one of the extension studies. It is open label, and it looks at 2 doses of zuranolone, 30 milligrams and 50 milligrams. What percentage of patients are in remission after long-term treatment? So this is up to a year out. 50 milligrams only extends to 6 months. Studies are still underway. There are 12-month data about 30 milligrams. And with 30 milligrams, a year later, 67% of the patients are still in remission, albeit in open label study. And with 50 milligrams, 6 months into it, 63% of the patients are in remission. So what would happen if after 2 weeks they declined? There are clinical criteria, including changes in depression scores, need to be hospitalized, both physician and patient, ascertained decline in mood. In that situation, patients can be retreated. And it is another 2 weeks of zuranolone treatment, oral treatment. How did patients overall fare in the long run? Well, almost 70% of the patients were good with only 1 or 2 2-week treatments in the course of the year. Were any of them on antidepressants? The answer is yes, but a relatively small portion, between 25 and 30% of the patients were taking antidepressants. The remaining 2/3, 3/4 of the patients were only receiving 2-week treatment of zuranolone at a time. That is it. So again, a different paradigm, different approach. And another allosteric modulator, another synthetic analog of allopregnanolone, it's called ganaxolone, and preliminary evidence suggesting its efficacy. So what are some of the takeoff messages? Well, number one, where are we? We said that that is one of our objectives. We're not in an enviable place now. And while significant number of depressed patients will respond, we know that, to monoamine modulating antidepressants, we're dealing with about maybe 35, 40%. Patients will fare well with these strategies. A significant number of patients will not. And it's quite possible that these individuals, due to the biological heterogeneity of MDD, may have a fault, excuse me, that is more closely related to GABA and glutamate transmission. We are also seeing some preliminary evidence that GABA and glutamate modulating agents may have much more prompt response, may have different quality of response, and are also capable of being sustaining in the long run. They also may modulate inflammatory signaling. They may increase neuroplasticity. So there is a promise on the horizon. And there is some initial evidence that even psychedelics may have a role in treatment of MDD. And with that, I will thank you on your kind attention and conclude this talk. Thank you very much.
Thank you, Dr. Maletic. Another terrific talk, which generated a number of important questions. And I know we're a little bit over time into people's lunch break. And so let me sort of consolidate some of the questions together for you.
Please.
The first may be answered fairly quickly, and that is, will the findings related to the difficulty with glutamate and GABA balance has there been any data to show that they might help with anxiety as well when we start looking at how these things are working in the brain?
Absolutely so. So there are some preliminary studies. There are sub-analysis of zuranolone given in postpartum depression. And it was associated not only in reduction in depression score, but also reduction in Hamilton Anxiety Scale scores. So zuranolone seemed to be quite effective in addressing anxiety in peripartum depression. There are also data on ketamine, and again, these are very, very, very preliminary, and it's unusual method of administration. So this is subcutaneous ketamine, showing that individuals who had anxiety actually had preferential response. So there are some early and preliminary data. I know that there's an interest in studying zuranolone in anxiety disorders and even PTSD. So please stay tuned, but there is some early indication that these agents may be helpful for anxiety.
With regard to esketamine, it appears that it may need to be continued indefinitely, or that's the question. Does it look like that may be true?
Yeah, in some patients, yes. So I've had all kinds of outcomes. I've had patients who have had 2 treatments a week for a month, 1 treatment a week for 2 months. Their depression cleared and they remained on monoamine modulating antidepressants. On the other extreme, I have a patient now who has been on esketamine for 2 years. And when we tried to decrease frequency of treatments, depression returned. So for the last 4 or 5 months, this patient was again on 2 times a week treatment, and just a couple of weeks ago has now returned to once a week. So indeed, there may be patients who will require ongoing treatment in order to maintain their benefits.
Is are ketamine more promising than ketamine at this point?
There are few studies, and these are based on animal models of depression, studies mainly coming from Japan, where there is indication that R-ketamine and its metabolite may be comparable, may be as efficacious, and potentially have less of dissociative phenomena, but controlled human data are lacking. So right now, unfortunately, that question is not answerable.
Okay. With regard to the ability for these kinds of agents to help with neuroplasticity, and the question that we don't know is, will the neuroplasticity be sustained? I think you mentioned that earlier. It appears to be true of the psychedelics as well as the other drugs that you mentioned.
Unfortunately, most of the data so far are from animal studies. And there is a very prompt increase in neurotrophic factors. So BDNF, brain-derived neurotrophic factor increase in animal models is measurable within hours of administration of the compound. There are studies where unfortunately animals were sacrificed and they looked at arborizations and emergence of new neural spines. And indeed, it was noted soon after administration of the compound. Obviously, that kind of study cannot be conducted in human beings, but neurotrophic factors can be measured. Most of the studies will measure peripheral levels of BDNF, but again, no consistent findings with esketamine so far.
And a last comment that came about was with regard to the similarity between certain kinds of long-term mindfulness and meditation practices have similar brain changes to, or assumed brain changes to psychedelics, but those are by their own practitioners preferred to be repeated indefinitely. So the practices are repeated indefinitely, and there's very little support, even with ancient wisdom, that someone can be enlightened once and be perfectly enlightened for the rest of their life. So the question that arises is, will there ever be, or can there be, human studies of the people who use their own mindfulness practices, and especially the ones that are more associated with the things that are similar to what we see in hallucinogens.
So looking at studies with mindfulness meditation, there are studies that come from the Montreal group, and these are structural imaging studies showing that intensity of practice of mindfulness is associated with change in gray matter volume. So we do have preliminary data that support indeed neuroplastic effects of mindfulness meditation. But again, it is related to frequency and time investment into mindfulness. So individuals who did it the most and had the greatest number of sessions, they're the ones where you would see the more pronounced effects. So yes, Montreal group has published that.
Those are the questions that I have.
I have one, Cliff, if you don't mind. So Dr. Maletic, when I first got into the field long ago, we would always talk about medications by themselves were about 50% effective. Talk therapy by itself was about 50% effective. And then if we combine the two, we might be seeing 75 to 85% effectiveness. And so my curious question is, with these new agents, where do we stand with the concept of combination therapy with the new developments we're seeing?
Right. It's an excellent question. Area where we may have preliminary but the most consistent answers due to the protocol that was utilized is with psilocybin with psychedelics. So psychedelics in many instances or their administration was sandwiched between therapy sessions, and there was some very supportive simple therapy going on during the 8-hour session that followed administration of psilocybin. So the interesting part is that psilocybin does not really act as a conventional antidepressant. In the only published controlled study, didn't really separate from escitalopram. However, if we look at some of so-called mystical dimensions, so expansions of insight, joy, feeling at one with the universe, intensity of those experiences, especially if harnessed in psychotherapy, that kind of synergy, that kind of synthesis seems to be very therapeutic. So again, there is some initial indication that it will be combination of so-called psychedelics with psychotherapy that will produce these lasting effects. The only long-term study that was published looking at the effect size of psychedelics over the course of 6 months is Robin Carhart-Harris. And what was noted is that after a couple of administrations of psychedelics, there was a pronounced effect. Effect size was a double, triple what we see with antidepressants. Now, I have to be very careful in saying that because the control was baseline. It was not placebo or any other agent. I'm saying not placebo because frankly, it's very difficult to blind psychedelic studies. Because if somebody is dissociating on saline, they have other issues, let's put it that way, right? So it's hard to really blind psychedelics. But in these studies, there was noted decay over time. So 3-4 months into it, indeed, the scores were not as impressive. And frankly, very few patients who have had treated with psychedelics, that has been their experience. Early on, robust effect, and then diminishing again. This is not a scenario where there was a systemic psychotherapy provided in conjunction with psychedelic treatment. And that is the combination that I believe will be most efficacious in the future.
Great, thank you. Hey, Cliff, have we exhausted everything?
I think so. There's a lot of comment about what a great presentation, what
Yes.
a wonderful ability to translate really complex research data and neuroscientific data into something that's understandable by many mental health professionals who don't have the same background. So much appreciated.
Great.
And thank you very much for the opportunity. And I want to thank our audience for staying with us even through the lunch breaks. So very much appreciated and very grateful.